You guys want to actually ask me about what resuscitation formula we use?
Welcome back to Pete's Crit. I'm Zach Hodges, and I'm here with Alice Shanklin.
Yes, and today we are back for part 2 with Dr. Samuel Mandell. He's an associate professor in the Department of Surgery at UT Southwestern Medical Center. He specializes in trauma surgery. He also does surgical critical care and comprehensive care of burn-related injuries. He is the director of the Parkland Regional Burn Center in Dallas, Texas, and we are so excited to be talking with him.
And here on part 2, we do a deep dive into these classic formulas that we use. We also continue our conversation with Dr. Mandell on his practical approach to caring for the critically ill burn child.
Yes, let's get right to the interview. So we've talked about this initial resuscitation vaguely. Mm-hmm. How do you recommend calculating the required volume?
Yeah, so there are probably upwards of 30 or 40 published resuscitation formulas. And I would say that none of them is exactly right and none of them is exactly wrong, right? They're all giving you a place to start. And then you have to titrate from there. I would say that the 3 most prominent that you'll hear about today are the Parkland formula, the modified Brook formula, and then the military using the rule of tens. What we use at Parkland, and this may shock you, is the Parkland formula.
I love it.
So we've modified that a little bit over the years. So the original Parkland formula, the classic, is that you take the total body surface area burned as a whole number. So for example, a 60% burn, you would use the number 60. You multiply it times the weight, and then you multiply that times 4 milliliters. And then you want to give half of that fluid over the first 8 hours, and then the second half over 16 hours. And so you take TBSA times weight times 4, divide by 2, divide by 8. That's the Parkland formula. I typically don't start at 4, I start at 3. That's in part sort of this response to the phenomenon of fluid creep that we saw in the late 90s, early 2000s. So I generally speaking start at 3. The American Burn Association publishes a consensus formula, which is essentially the Parkland formula, but they actually recommend starting at 2 milliliters for kids. There's nothing wrong with that. I have found that in my practice, I think that people are starting to swing a little bit to being too shy on the volume. And so that's why I like to start at 3 and then keep a pretty close eye and back off once we see the response. So even though these are formulas, you'll see there's still quite a bit of art there. So the way I employ the Parkland formula is total body surface area burned times the weight times 3 milliliters, and then divide by 2, divide by 8. Now, this whole 8-16 thing, I worry much less about that, and I worry a lot more about the response to the resuscitation. So I'm looking at the urine output. Where that total fluid volume that you got is nice is it allows you to sort of think about what a target might be. So you can start to say, am I way over what I predicted? Am I way under what I predicted? Or am I sort of in the ballpark? And you kind of want to be sort of in the ballpark if the resuscitation is going well.
Just to conceptually wrap this up, so the patient who's injured in the field, I see you start them off in that round number, 125 or 250. You get them to the ED or ICU, you get them resuscitated, you have a chance to look at things head to toe. That's where these formulas come into play. Is that right?
Exactly. And the reason that we went with those, and the American Burn Association recommends using those sort of initial fluid rates, is because what we found, right, is burns are big. They're sort of impressive, scary injuries. There's a lot going on. And, what you don't want is to get in a situation where you're focused on this big cutaneous injury. People are doing wound care. People are worried about ruling out trauma. People are getting this settled. And before you know it, you look up and an hour has gone by and you haven't calculated the TBSA to the nearest 1%. And people were worried, so they don't start any fluid, right? We want to avoid that. So you can start your resuscitation. And then, a little bit later, you can do your secondary survey. You can get a more accurate estimate of your TBSA, and then you can do the calculated formula.
I've read previously that different types of burns have different fluid requirements. Do you see that practically play out in your day-to-day practice?
Yeah, I think that's true. Inhalation injury will increase your fluid requirements. Generally, deeper burns and flame burns tend to be deeper than scalds. You can see more fluid requirements. I think we see some variation there, but for me, it's not enough that I sort of hang my hat on that in terms of guiding resuscitation. But if I see really deep burns, big inhalation injury, I start to think, this person maybe is going to need, or I can expect a rockier resuscitation than I might otherwise. But I think it's also just like in other areas of medicine, trauma, sepsis, right? The inflammatory response is different in different people. And we don't have a way of predicting how that's going to go for an individual patient yet. Figure that out, you get the Nobel Prize. So
the inflammatory subtype. I had not thought about that in relation to burn, I will say.
A lot more sepsis on our brain in the PICU.
So we've talked about Parkland, your percent body surface area affected times the weight times between 2 to 4 mLs. Divide by 2, divide by 8 to get your initial resuscitation rate. How does this change in the modified Brooke formula?
So the modified Brooke formula, very similar in terms of the crystalloid calculation. So still TBSA, still going to use the weight, but here you're using 2 milliliters per kilo. Still doing half the total fluid requirements in the first 8 hours. The major difference is that you're going to add in albumin. And I think the original Brooke, it's like half mil per kilo per TBSA. And so the modified Brooke has a standard albumin rate built into it. That's the main difference, is it's 2 mils for the modified Brooke.
I think that the common theme throughout the formulas makes it easier to remember as well. And the way that different people vary it depending on how much of a steward of fluid they want to be in the moment.
Yeah.
That's very helpful.
So another formula that I found in reading was this rule of tens, where you take the total body percent burned and then multiply times 10 for that initial fluid rate. Do you see that used very much?
So the rule of tens comes out of the military, and some places do use it. I think a couple things to remember about the rule of tens is, number one, it comes from the military, and 2-year-olds don't serve in the military. So, it might not be the best choice for young pediatric patients. 17-year-old, go for it. And, again, just like all of the rest of them, it is a place to start your resuscitation, and it was designed to be simple, just like those initial fluid rates that I gave you, so that if you're out in the field and you need to calculate quickly how to resuscitate somebody, it's very easy and straightforward to do. So yeah, it is used. It is a choice, as a nice place to start. But, again, for my practice, I still stick with the older Parkland formula, particularly in the pediatric group.
And we'll be sure to include that formula in our show notes.
It's just percent body surface area times 10, right?
Yeah.
Yep.
For the hourly fluid rate for adults.
So we've got the patient in front of us. They've come through the trauma bay and up to the ICU. How should we generally approach how to initially dress and just sort of put the dressing on these burns? How are we doing
What do I do with the burn?
Right? It is emotional. I agree with you.
So number one, remember, especially in kids, right? These kids are going to be losing heat like nobody's business, right? Kids are already, big outsides, little insides. It's why they're so warm and cuddly, right? But these kids now have damaged skin, and they have a really high surface area to body ratio. And so they're going to be like just losing heat like nobody's business. So when you're doing wound care, or your initial wound care for these large burns in the ICU, warm up the rooms, right? Get ready to do it. Don't just be like taking the blankets off and like, here we go, wound care in the emergency department. No, get the room really warm. In fact, I would say get the room hot, right? So this is a good time to think about the patient comfort, not our own. If you're comfortable in a gown in the room, it's probably not hot enough for the patient. So warm up the room, get ready with warm IV fluids, make sure you're maintaining the patient's temperature. So then for washing the wounds themselves, keep it simple. Warm, soapy water and a washcloth is all you need. We generally speaking will use chlorhexidine soap initially, gentle debridement, or Johnson's baby shampoo, something like that. Warm, soapy wash. Get the loose debris off. You don't need to scrub. You just want to get most of the dirt, debris, loose skin off of there. And then for the initial wound care, For large burns, I like to keep this really simple, particularly if you're talking about, somebody who's going to need operative therapy down the road. For patients who have, particularly who are intubated and have good sedation and pain control, I use something very easy like Silvadene or bacitracin and greasy gauze. Or I should say silver sulfadiazine cream, which is the non-brand name version of that.
So either Silvadene or Vaseline
with bacitracin.
Yeah, or bacitracin and some greasy gauze, right? And so the idea here is you're keeping the wound bed moist and you're providing an antimicrobial treatment. What's the best antimicrobial to use? I would say one, no one knows. But two, there have been Cochrane reviews on this, and one does not seem to be better than the other. The reason that I choose Silvadene for some of these patients early on, especially with full thickness burns, easy to apply, cheap, broad spectrum antimicrobial. So it's easy on the nursing care and it's soothing early on. So it makes a great initial dressing, especially if you just need to get something on the wound quickly. Xeroform or greasy gauze and bacitracin, very similar, cheap, easy to use, good gram-negative coverage, and go from there. There are for sure long-term silver-impregnated dressings or other long-term dressing solutions. Those are great for partial thickness scald burns in the pediatric population, particularly those who are not going to be in the ICU. But I do use those in the ICU as well for wounds that are clearly partial thickness. Those can go a long way towards reducing pain and anxiety by reducing the number of dressing changes that you need.
Nice.
Sure.
So I like to keep it as simple as possible. I take into account, keeping the wound moist, what my antimicrobial spectrum is going to need, and then what is this going to mean for the patient in terms of need for dressing changes, pain, and sedation.
And that makes sense. So big picture, keep the room warm, be mindful of your exposure, debride these wounds very cautiously with mild soap, and then put something that's going to keep that wound moist and protected with antimicrobial.
Yep.
I feel like the conversation always comes up, do we pop the blisters? Is there any kind of general principle that you tend to recommend people do in the field or the outside referring institution about these blisters that we tend to see?
There is. And I love general principles because if you remember general principles, particularly in the ICU, you can practice in multiple settings without a problem. If you remember a particular product, then all of a sudden when that's not available to you, you're like, ah. So the main rule on blisters is that if it is in the way, get rid of it. So if that blister is going to prevent the patient from participating in physical therapy, doing an activity of daily living, performing self-care or assisting in other care, the blister should go. If the blister is flat, not likely to pop, and does not get in the way any of those things, you can leave it alone.
Nice. So a blister on the hand versus like just a random blister on the arm or something that's not going to bother the patient. You don't need to physically debride it.
Yeah. So if it's on the hand and flat, so if it's on the hand and they can make a fist and that blister is not getting in the way, you can leave it alone. If it's on the hand and they're not going to be able to make a full fist or stretch their whole hand out, that blister's got to go. Similarly, on the arm, let's say, if the blister is flat and not problematic, you could leave it, but more often than not, these are going to be big and floppy. And as soon as that patient tries to do anything, it's going to pop and there's going to be, so just get rid of those as well.
Nice.
Hey, I'm Ciara Minova, a graduate student of Psychology and Neuroscience of Mental Health at King's College London, and I'm so excited to share with you my new podcast, which is called Behind the Stigma. Every other week, I will be mainly talking to the podcast clinical psychologists, clinicians, researchers, educators in the field, you name it, basically people that I find so inspiring and that will help us understand the latest research, concepts, but also complexities and controversies surrounding mental health. These are going to be some great discussions and a peek into the fascinating world of psychology, neuroscience, and psychiatry.
Yeah, that makes sense. And I think that's a helpful general principle. If it's going to impede the patient's recovery, just go ahead and take care of that at that time.
In the ICU, for the most part, right, if the patient is making it to ICU level care because they have that large enough burn, you're going to be debriding most of the blisters. The blisters that we're really leaving intact are really in these much smaller, closer to outpatient management burns.
Mm-hmm. Sending home for the ED, you don't need to like do a really aggressive debridement.
Correct. You don't need to get like every little last blister off, right? In fact, it's not desirable to, right? Big floppy blisters are easy to take off because the blisters itself is dead skin. It has no sensation. You grab it and you just trim around the edge. It's when you're trying to get down to these like tiny things that are stuck very close to the wound bed. That's when it's painful because that's where all the nerve endings are.
That makes sense. As we move forward, something that as a medical provider, I don't think about very much, I'm not really most comfortable with, is compartment syndrome. But I do know these patients with burns can have, full burns or, surrounding a limb or even over the torso that might affect ventilation, and they may need an esteriotomy. Are there any particular clinical scenarios that would make you really heightened your suspicion that the patient might need an esteriotomy?
Yeah. So full thickness burns are where this tends to happen. Full thickness burns that require resuscitation, even more so. And then full thickness burns that are circumferential in some way are at the highest risk, but they don't have to be circumferential, right? So for example, what's happening here is the skin that's burned is becoming dry and leathery and non-compliant. It doesn't stretch. And so as the patient swells against it, mostly from the resuscitation, that skin doesn't stretch, and that's how you get the compartment syndrome. So you can actually quite imagine that if you have a burn that's mostly circumferential, right, it can have enough limitation on the stretch that you can still develop compartment syndrome, right? So I do think you want to make sure here that we're understanding the physiology of what's happening and not just being like circumferential, not circumferential. Because a partial thickness burn that's truly partial thickness that's circumferential is at really much less risk for this happening. So we're worried about full thickness burns. Generally speaking, the swelling is going to come from our resuscitation. So very often this is going to pop up in that sort of 6-hour window, right? It's not going to be present on admission usually. So that's good. It means that when you're first seeing these patients, escharotomies are rarely a dire emergency, right? They can almost always be done a little bit later, and they can almost always be done in consultation with a burn specialist. Now, you did mention the chest, and that can be important because the chest wall has compliance to it as well. And what you're seeing with this problem is if the anterior chest in particular is burned very deeply, you lose that chest wall compliance. It can be challenging to ventilate patients. You will see their airway pressures rise. And so we do escharotomy on those occasionally. Again, really rare that that's going to be right out of the gate. You're usually going to have some time. And then the treatment is to release the eschar, to cut through it down to the fat. It's important to remember there's no need to cut the fat here. All we want to do is release the skin. That's what's causing the tension. And so when we do eschorotomies, we just go down, we just get right through the dermis, and that's enough to release the tension. And that's really all we need to do. There are 3 other types of compartment syndrome that we need to worry about. So number 1 is muscular compartment syndrome. That definitely can happen in burn injured patients. Places to worry about that. So high voltage electrical injury may need true fasciotomies, right? So release of the muscle fascial compartments, not just the eschar. Patients who are found down after a long period of time. This can sometimes happen, right? Those patients are at risk for muscle breakdown, just like patients who aren't burned who are found down after long periods of time. Those patients can also need muscle releases. And then patients who have been over resuscitated or have a really challenging resuscitation and get massive amounts of volume, right? You can, in fact, get enough swelling of the muscle that this is something to worry about. That level of resuscitation also leads to the other 2 types of compartment syndrome we need to worry about. Abdominal compartment syndrome, relatively rare these days, particularly in kids, as we've backed off on the amount of volume that kids are getting, but that is something to worry about. And then ocular compartment syndrome. So it is possible to get compartment syndrome of the eye. And so for these folks who are getting large volume resuscitations, we do have the ophthalmologist come and measure eye pressures. And the treatment for that is actually a lateral canthotomy if they have elevated intraocular pressures.
So we've got muscular, so not restrictive skin, but muscle swelling. We've got abdominal compartment syndrome and then ocular compartment syndrome. I have to tell you that I read about ocular compartment syndrome for the first time preparing for this episode. And thinking back to some of the patients I've been peripherally involved with and just hadn't thought about it at all, can you look at a patient and know that it's time to get ophtho involved, or is it a little more complicated?
No, it's more complicated than that, right? I mean, you're really talking about the pressure on the globe itself. So you can't just look at the eye and know that you have it. And so generally speaking, for patients who are getting large volume resuscitation, we'll get the eye pressures measured.
So not clinically, I see the swelling and I'm worried about it, but just this is part of our protocol to keep our patients safe.
Correct. Because their eyes are going to swell anyway. I mean, their actual conjunctiva is going to swell quite a bit, and they're going to look very volume overloaded, but that doesn't necessarily mean that the orbit, the globe itself, is under excessive pressure.
And when you're thinking about doing an escherotomy or even a fasciotomy, do you rely on measuring compartment pressures, or is it more of a clinical diagnosis?
No, it's definitely a clinical diagnosis. Certainly for escherotomy, compartment pressures we do measure in the eye. You know, compartment pressures in the extremities in terms of muscle compartments can be useful, but it requires some familiarity with the equipment and really being good at measuring those pressures. Orthopedists will have that expertise in many cases, but in many others, people really don't. And so I really caution people against being falsely reassured by compartment pressures, right? So I might think of them as an early warning system. If the pressures are going up, they might say, oh, maybe I need to think about this. But if you clinically think that you have compartment syndrome and you get the pressure, it's not as high as you thought, be very careful about being reassured by that. If you think you clinically have compartment syndrome, I would err on the side of releasing the compartment. And for escherotomy, right, as long as you're cutting through the full thickness burn, you're not losing anything. The danger there is really inexperienced providers will sometimes cut very deeply into the tissue, almost down to fascia. And that can be challenging to reconstruct later because we can't just put that fat back.
And then you'll end up sort of with a wound vac over that.
Yeah, or a skin graft with kind of like a big valley in it. Or we have to excise deeper to smooth that out. The thing about fat is, that you learn in the plastic and burn surgery world, right? All of the soft curves and things that we like about our bodies, that's all fat, right? So it's sort of like the slope of a back, for example, as it comes down into your hip. Fat is what makes that possible. The iliac crest and the back itself have almost a divot. There's almost a triangular shape in there. Fat is what smooths all that out. If you excise the fat, it does not grow back. And so when you make an escherotomy incision all the way down to the fascia, that fat doesn't grow back there. And so you'll always kind of have this gap that can be challenging to reconstruct later on. If you think about sort of a laparotomy scar or a wound that's a really deep wound that we let granulate, they look indented, right?
Yeah.
And that's because you have scar going down towards the fascia and you lose fat in that area.
Makes me appreciate having specialists like you guys who can help us with that stuff. Yeah. As we move towards the last couple of questions for you, this is kind of the one I think is most important. You're always happy to loop you guys in if we're worried about a kid who's been burned, but are there any specific or general indications that you always think, or maybe nearly all the time, those patients should be managed in a burn center?
Yeah, well, so number one, I think, so the American Burn Association has referral criteria that are good to look at. They're pretty broad, but I think a good rule of thumb. In general, I think if you are an ICU practitioner and you are admitting a kid for a burn to an intensive care unit, you should probably be doing it at a burn center.
Yeah.
I think that's probably a pretty safe way to go. Now, that can look a little different depending on where you are and what the relationship with burn care is. But in general, if the burn itself is large enough that you're talking about resuscitation and reconstruction, those patients should be seen in burn centers. And the reason for that is it's not just any one aspect of care, right? It's not just, and we all can get stuck in this, right? Like, oh, I can do the ICU care or the resuscitation. That might be true, but you also need the physical therapists, the occupational therapists, the child life specialists. You need, the wound care expertise. You need the surgeons that can do the excision and grafting, the rehabilitation physicians who can help with, rehab needs. You need the reconstruction specialists who are going to be looking at the long-term outcomes, right? There's a whole package that goes along with it. And so, like many of these complex patients, each of us kind of has a slice of that role to play. And it's important to remember that there's a whole lot of support that goes in and around that it's important to have.
Oh, absolutely.
I think it's easy for us as PICU fellows to get really focused in on those initial few days, initial resuscitation, and really forget, or at least not think about, all the support structure that goes into taking care of these burn patients, even as they start that process of getting out of the hospital.
And most of those things should start on day one, but burns, especially large burns, right? You're talking about weeks to months of acute hospitalization, and then, months to years of rehabilitation recovery from larger burn injuries. And so the critical care is an important aspect, right? And particularly up front, because if you don't have patients surviving that, then you don't have anything to reconstruct. But all of those things, all of those therapy modalities, nutrition, pharmacy, et cetera, all of that has to start from day one as well.
Nice. We could talk about the best way to secure an endotracheal tube or a nasal tube if you wanted, but that seems like a rabbit hole.
It is a little bit. I think the best way to secure an endotracheal tube is so it doesn't come out.
Yes.
And what I guess I would say is, this isn't unique to burns, but I think burns are something that people, generally speaking, are not always familiar or comfortable with, right? And so when you are faced with a condition that is outside of your comfort zone, that is not the time to change practice, right? So that is not, if you have this way that your RTs have always been tying endotracheal tubes, right? A one-off burn that comes into your center that has to be with you for a little while is not the time to try to reinvent how you secure endotracheal tubes. You should secure it the way that you know how.
Right. That keeps it in until they get to the burn center.
Now, some principles that you can certainly go with are, right, avoid pressure or excessive pressure, right? People who have loss of skin integrity are going to be more sensitive to pressure on their skin. So that's good to do. But yeah, when you see a big burn, that is not the time that you want to try to kind of reinvent a whole bunch of new processes on the fly. It's just, it's sort of like with mechanical ventilation, right? What's the best mode of mechanical ventilation? The one that everybody knows how to use.
So don't mess around.
So that you can troubleshoot, that the RT understands, the person coming on next shift is comfortable with, for sure. Well, for our last question before we let you go, is there anything you wanted to reinforce? Is there any 2 or 3, 4 points that, the next time we have that burn patient in front of us, you'd like us to definitely remember?
Yeah. So I think the key things are start your resuscitation early, right? And then I think make sure that you are tailoring your resuscitation to patient response, right? Those are the two main things, where I see, challenges come up. It's either people are just bolusing right away because, and I think it's just sort of, this is scary and I know that they need volume. So here are a bunch of boluses, right? But if you give 5 boluses in that first hour, it doesn't change the fact that they still may need a high volume of fluid in the second hour. So start early and then make sure that you're tailoring your hourly resuscitation to patient response.
Well, thank you so much for joining us today. We learned so much from this episode, and I can't wait to sort of level up my own personal care of these patients.
All right, well, I'm glad that you found it. I'm glad you found it helpful, and I'm always happy to come and talk about burns. So,
hey, yes, that sounds great.
And thank you for listening to this episode of Pete's Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Pete's Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Pete's Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.